Good morning, everybody. My name is Francisco Bertomori Fredes. In this presentation, I will be going over the case of Mr. David Nazal, who's a 62-year-old male who has been referred to the emergency department for a medical history of COPD exacerbation, along with an infection derived from COVID-19. I will be explaining his A2E assessment, priority nursing interventions, and his medications with the nursing considerations. Okay, so for question one, we'll be starting with his A2E assessment. Firstly, airway. At this moment, it is visible that David's airway is clear and there are no signs of obstructions nor any difficulties that could be affecting his speaking. This is a positive indication. However, it is crucial that we continue to monitor his airway as COPD exacerbation has resulted in increased volumes of built-up purulent mucus. Due to a potential buildup of mucus, it will be important for the suction or use substitute hygiene measures to prevent occlusion of the airway. Breathing. David's oxygen levels are sitting at a low 78% on room air and is currently taking up to 30 breaths per minute, which is a possible indication for tachypnea. There are indications of findings such as decreased sounds of breathing persisting on both sides of his chest and persistent sounds of crackling and wheezing coming from the bases of the lungs. He is suffering from severe respiratory discomfort due to using his accessory muscles to help him breathe. David's arterial blood gas levels notify us of respiratory acidosis, which is due to an increased PaCO2 of 60 milligrams of mercury and hypoxemia with a PaO2 of 55 milligrams of mercury. Immediate course of action is required by giving David bronchodilators to prevent airway resistance and allow for regulated oxygen therapy to function, allowing for desired levels of oxygen for patients with COPD, which is the normal range of 88 to 92%. Circulation. David's heart rate is 128 beats per minute, which is a sign of sinus tachycardia. This is likely a result of hypoxemia and respiratory distress. David's blood pressure is around 168 over 85 milligrams of mercury and 3 seconds for his capillary refill, which is a probable result from coldness and or poor circulation. Circulatory and respiratory strains are to be regularly monitored for any signs of cardiovascular conditions that may be presented, as a combination of both can lead to acute heart failure or other complications. Disability. David has presented himself with a GCS of 14 out of 15, indicating a neurological disorder and disorientation. Signs of hypoxia can be seen due to the result of a decrease in David's oxygen saturation levels. Continuous monitoring of David's GCS and tests of his respiratory condition will help detect any deterioration of his hypoxia. Exposure. As per observations, David is febrile, which is a result from the infection, most probably due to this COVID-19 infection that is worsening his COPD. Skin is intact with no signs of breaking or tearing, no tenderness, and can be seen in the stomach, and bowel sounds are normal, but continuous monitoring is critical for any systematic changes. Okay, so we'll be moving on to our priority nursing interventions. First, priority nursing interventions involve oxygen therapies, nebulized bronchodilators, antibiotic therapy, and a check and follow up on David's ABG results and vital signs. Firstly, we'll be starting with controlled oxygen therapy. The main objective is to bring David's oxygen saturation in between the range of 88 and 92%. Thus, implementing controlled oxygen therapy will assist in bringing up his low oxygen of 78% on room air back up to 88 to 92%. Not providing him with adequate oxygen can worsen his hypoxemia and lead to symptoms such as confusion and difficulty breathing. Nebulized bronchodilators. So we have salbutamol and ipratropium and are drugs administered through a nebulizer and should be dosed as per protocol. Salbutamol is to be given every 2 hours, whilst ipratropium every 6 hours. Both medications work by relaxing the muscles, opening the airways, and relieving bronchospasms, therefore reducing the use of muscles when breathing and improving airflow. Azithromycin, which is antibiotic therapy. So azithromycin is a life-saving drug that is needed to treat bacterial infection that is aggravating David's chronic obstructive pulmonary disease exacerbation. Azithromycin can also treat community-acquired pneumonia and sexually transmitted diseases. Azithromycin immediate effects is a relief on the purulent mucus and the causative bacterial infection. And lastly, we have controlled monitoring of vital signs and ABGs. Doing regular checks on David's respiratory rate, oxygen saturation levels, and arterial blood gas levels will provide us with adequate data in regards to his health, informing us if any changes are needed regarding medication and treatment, as well as determining if his health is deteriorating. The data provided will also be used to determine the state of his lung function and the use of oxygen therapy and bronchodilators. Okay, so we're moving now to therapies and medications. So now turning to his medication and therapies, we'll be conversing about the assessment and administration and adverse effects of administering therapies. The first therapy is oxygen therapy. For this section, I have divided everything into assessment, administration, and adverse effects. So oxygen therapy, firstly, we have assessment, which is this is to maintain SpO2 levels within 88 to 92% to prevent hypercapnia, continuous assessment of the work used for breathing and monitor mental status for any indications of hypoxia or hypercapnia. For administration, we have provide oxygen through a venturi mask or nasal cannula with enough time for the effects to settle. And for adverse effects, we have monitor for hypercapnia as it is common in COPD patients and the drying of mucous membranes. For salbutamol, we have assessment, which is to monitor the patient's blood pressure, heart rate, and listening to the sounds of the lungs before and during use. Administration, use nebulizer treatments every 2 hours PRN and facilitate the reduction of dyspnea, dyspnea, and coughing. Adverse effects, the common side effects such as tachycardia, tremors, and nervousness. It is important to monitor David's heart rate as he already has sinus tachycardia. Moving on to ipratropium bromide assessment, which is continue to monitor breath sounds prior to and post administering medication, especially if the dose is high. Administration is ipratropium is administered through inhalation. This can be either through oral ingestion or intranasally. Nasal sprays, inhalers, and nebulous solutions are some of the forms of available administration. Adverse effects. Common side effects are headaches, dizziness, and dry mouth, but the side effects can be usually tolerated due to the lack of the severity of the actual drug itself. Prednisolone assessment is evaluate David for infections, vital signs, mood, and any behavior changes, as well as a physical exam. Administration, general routes of administration of prednisolone is oral or injection administration to be given with food or milk to minimize GI discomfort. Adverse effects. Some common side effects of prednisolone are hypertension, hyperglycemia, insomnia, and an increased appetite. And lastly, second last, we have azithromycin, which is what we spoke about before. We have the assessment, which is prior to administering azithromycin. We need to confirm David's allergies and see if there's any possible allergic reactions to macrolides or ketolides. Administration azithromycin is a medicine that has to be given through either the IV route or orally. Generally, you want to consume this drug with or without food, whilst a slow infusion if through an IV. Adverse effects are some common adverse effects of the consumption of azithromycin are upset GI, rashes, headaches, and dizziness. And lastly, we have nirmatrelvir and ritonavir, which the assessment when preparing the administration of nirmatrelvir and ritonavir, it is important that we confirm the COVID-19 diagnosis of David for any symptoms, assess his renal and liver function. Administration of nirmatrelvir and ritonavir are to be given orally and typically given as 300 milligrams of nirmatrelvir and 100 milligrams of ritonavir twice daily. Tablets are to be consumed together with or without food. If David suffers from any renal complications, the dosage should be reduced or adjusted. Adverse effects, we have some common side effects from the consumption of these drugs are an upset GI, potential hepatotoxicity, headaches, and dyschezia. Okay, now we're moving on to my reference list. I use a handful of references to help me with my for my case study, for my presentation. And we're just moving on to the last slide. So in final thoughts, COPD exacerbation and COVID-19 infection from the core of the back and forth scenario of Mr. David Nazar underwent, exerting a great deal of pressure on his breathing and blood circulation systems. Based on a standard A2 assessment, we isolated critical areas such as compromised oxygenation, respiratory distress, and infection. Paramount nursing techniques along the lines of coherent oxygen therapy, bronchodilator delivery, and defeating the infection are the primary healing methods to his sickness. Following the regular checkup to his vital signs, ABGs and medication side effects will be provided to attain adequate recovery and support his recovery. Thank you very much for tuning in to my presentation. Thank you.